Hi, today I'm going to be covering MS or multiple sclerosis. And so multiple sclerosis is an autoimmune disorder. The cause of MS is not known at this point, but it's an autoimmune disorder that attacks the central nervous system and specifically attacks the myelin in the central nervous system. The myelin is this fatty sheath of tissue that insulates the nervous fibers and increases the rate of transmission for nervous impulses. When this myelin sheath is destroyed, what will happen is it will either reduce the rate of conduction, it will alter the path of the transmission, or it will actually completely block the transmission altogether, specifically if the nervous fiber is also destroyed in the process. So you have the scarring tissue over here. It's most likely caused by a combination of factors. So we have gender, family history, environmental issues, ethnic background, obesity, and then viral and bacterial infections. Specifically for viral infections, we have the Epstein-Barr virus, which is the virus that causes mononucleosis. And in several recent studies, it's been shown that there is a correlation between someone who is infected with Epstein-Barr virus and has mononucleosis and a future development of MS. So it increases the likelihood of developing MS. And then you have other viruses such as measles, herpes virus 6, chlamydia, pneumonia also being investigated. So 4 different types of MS. We have the clinically isolated syndrome, which is the first episode of neurological symptoms. So these are characteristic of MS. You will get the neurological dysfunction that occurs, and so you'll have this relapse remission point. So you'll have a relapse point where signs and symptoms will occur, and then eventually you will have a remission point where you will return back to normal. So because you have to have at least two bouts of relapse remission in order to be diagnosed with MS, this is really just a first step. So it does not necessarily even mean that you have MS. Some people will get the clinically isolated syndrome and never actually get MS. And then so we have, next one is going to be relapse remitting. This is the most common. So you're going to have clearly defined levels of neurological symptoms. So again, you're going to have the going up, the tapering off, and then you're going to have either a full recovery or only a partial recovery. And then you're going to have remission, where you're going to have a point where symptoms and signs don't come back. But at some point you are going to have another relapse where you kind of go back up. And then if you don't make full recovery, it's just going to continue to grow. And the signs and symptoms are only going to continue to get worse. And then we have the progressive MS. So secondary progressive is going to follow the same course, where you have the initial relapse where symptoms occur, and then you're going to eventually taper off, and you're going to have a remission. And then what's going to happen is you will not have any more relapse remitting. You're just going to have a progression of signs and symptoms over time that's going to slowly climb up, just like I'm kind of showing you on the monitor. And then we have primary progressive, which means that there's going to be no initial relapse remitting. It's just going to be a slow progression of signs and symptoms over time. It's either going to be active or inactive, so it might taper off at points, but the idea is that over time it's going to continue to get worse. The age demographic, so most commonly affects people from the ages of 16 to 55, but it can occur at any time. Women are 2 to 3 times as likely as men to develop MS. White Northern European descent is the most likely to have MS, and it's been discussed that the people further away from the equator have a higher risk than those who are closer. So leads researchers to believe that vitamin D and sun exposure play a key role in possible development of MS. Asian, African, and Native American descent are the least likely to ever develop MS. Family history is important because if you have a first-degree relative, so either a parent or a sibling who ends up developing MS at some point in their life, your likelihood for developing MS is increased. So That's something to look out for. And then another high risk category is people who already have autoimmune disorders such as type 1 diabetes, thyroid disease, or inflammatory bowel disorders such as Crohn's disease or ulcerative colitis. Signs and symptoms, every person presents differently, but in general you're going to have a loss of coordination and balance. It's going to you're going to have tremors, numbness, tingling, which occurs typically on just one side of the body in the appendages, so either a leg, arm, or both are going to have numbness and tingling, so it's going to feel like peripheral neuropathy. You're going to have slurred speech, difficulty speaking, difficulty swallowing. There's a sign called the Lhermitte sign, which is an electrical shock sensation every time you bend your neck forward. And then you have issues with sexual arousal, bowel and urinary control are lost, so you're going to have incontinence and visual issues such as blurred vision, double vision, partial or full loss of vision in one side of the eye, and then we also have potential pain behind the eye. So there's no true test for MS. Differential diagnosis is key, so you're trying to eliminate all other options before coming to the diagnosis of MS. So when somebody presents with numbness and tingling in the arms and leg, they're trying to eliminate peripheral neuropathy as the reason. So you're trying to figure out what exactly it is. Is it a pinched nerve, or is it something more serious than that? Blood tests and spinal tests can be used to help with differential diagnosis. So blood tests such as we'll be looking for things such as lupus. Spinal tests can be used to look for specific biomarkers that could help with an MS diagnosis. And the biggest thing you're going to see is an MRI scan of the brain. And you can see on this scan there are little white plaques all throughout. And what those are is demyelination of white matter in the brain. So that's where the tissue is being attacked, the myelin is being attacked and destroyed. Treatment for MS involves disease-modifying therapy. Progressive MS is very challenging to treat, and there are many less options available. Disease-modifying therapy can help in very small percentage of progressive MS, but most people it does not actually help. In cases of relapse remitting, there's corticosteroids to help with control the severity of relapse attacks. And there are many more options for relapse remitting MS, such as injections to reduce frequency or severity of relapses. Beta interferon injection is the most common medication. We have oral medications used to reduce the frequency of relapses, but often have severe side effects. We have an infusion treatment, which helps to reduce the immune system's response of the attack on myelin. And then we have a drug called Ocrevus, which is the only FDA drug approved to treat both relapse-remitting MS as well as progressive. So the field I'm looking to go into is physical therapy. PT plays a pretty important role in treatment of MS, as it does in most neurological or musculoskeletal issues. So for the most part, what PT is trying to do is keep people as functionally strong as possible. So making sure they can continue to use the stairs if they need to use the stairs, continue to be able to get out of their chair, be able to get down and up from the toilet, things of that nature. And so it's important to stay functionally strong, work on those different movements. It's important to continue to stretch and keep muscles loose, because as we become less active in situations where we do get a flare-up, it's important to continue to keep stretched out, because there becomes aches and pains with tight muscles. As I said, functional strength is the goal, but also working with any gait assisting devices such as a cane or a walker, making sure that they're using them correctly, make sure that they realize the importance of using them to avoid falling. Having the cane on the right side, cane at the right height, things of that nature. And then in most cases of PT, they help to design a home program. So you want to make sure that the patient continues to work on their own in the comfort of their house, to make sure that their couple visits of PT a week aren't lost during the off days, that you continue to work to build functional strength and continue to work on your balance and things of that nature. And then helping improve specific impairments. So anything that comes with the flare-ups, any specific symptoms that come about, you're trying to help them with through those. You're trying to, if their balance is off, you're trying to help improve their balance. If they lose a lot of strength, if there's a lot of neuropathy, things like that, you're trying to calm those symptoms down. And then last thing you're trying to do is educate and let them know what to expect going forward so that they're prepared. And then that is my reference page. All right, thank you.